All right, why don't we get started? Thank you all for coming. This is the third chief resident. Okay, one more to go. Okay, excellent. And so to introduce Dr. Fass is Dr. Laura Zakowski, our Vice Chair for Education.
Good morning, everybody. I really have the pleasure of introducing Dr. Fass today. Unfortunately, Dr. Coyle was going to be gone this weekend, so otherwise he would be here, but I feel I have a privilege here to be able to talk about somebody that many of us have worked with over the last several years. He is one of our categorical chief residents, as you all know, and he has served as the senior scheduling chief this year. As you can imagine, the logistical opportunities that exist and trying to balance the resident schedules, the clinical schedules, the patients, and what they need has been something he's managed very well this year. One of Dr. Fass's impactful contributions has been his work in expanding our nutrition curriculum. This first started several years ago with a Department of Medicine innovation grant, and Dr. Fass has kind of taken this to advancing the cooking classes and nutrition education along with several other residents who are in the audience. This is an initiative that brought patient-centered learning into our training in a very meaningful way and helps residents themselves kind of understand the importance of nutrition. And his passion for patient care and education extends into research too. Under the mentorship of Dr. Simona Saha in the Division of Gastroenterology, he has conducted important work in inflammatory bowel disease, of which we'll be hearing more about today. His work has been recognized nationally through presentations, posters, and oral presentations, and importantly, received a 2024 American College of Gastroenterology Presidential Poster Award for that. He completed his medical degree at Rush Medical College and then joined us here at UW in 2021. And he continued to distinguish himself through clinical excellence and commitment to community health. He secured a Sheehy grant to provide exercise equipment for physically and mentally disabled adults in Madison. So we're thrilled that Dr. Fass will be staying here to begin his GI fellowship this July. And on a personal note, he has a very exciting summer ahead of getting married, trying to learn Lithuanian, and so we can all please congratulate Dr. Fass on his professional and personal successes and to hear today more about his work. Thank you.
You guys hear me okay? All right. Thanks, Dr. Zakowski, for that very kind introduction. So today I'm going to be talking about integrative health in inflammatory bowel disease. We'll review the past, the present, and take a little bit of look into the future for what this could look like. I have no conflicts of interest today, maybe in the future, as with most young trainees. So this is, again, basically similar title slide. Maybe if I do have a disclosure, it would be that I'm secretly Bucky at heart. So I just want to say thank you for having me. It's a great privilege to be discussing this with you today or presenting today at Grand Rounds. I've had many roles at UW over the years. I've been an undergraduate researcher under Dr. Pentekar. I've filled out power of attorney forms under Elizabeth Boyle. I was a central pharmacy technician making TPNs and epidural bags. I don't remember who my boss was at that time. So if you're in the pharmacy, maybe ask around. And then I was a clinical research coordinator under the direction of several oncologists that we all know and love. And of course, chief resident and future GI fellow. So thank you. It's a pleasure to be here, not in the audience today, but speaking. So with that said, half the population has been estimated to utilize some form of integrative health, and that's both in developing countries and developed countries. So I would argue that this is a very important topic that we should be talking to our patients about, or at least have some sort of working knowledge to speak with them about. So with that in mind, I have a couple goals today. Outlining IBD and its burden as well as its chronic nature. We'll describe integrative health as a discipline. I hope to then take some time to convince you that a lot of our patients are doing this, not just show you a picture of a globe. And also convince you that we're probably bad at knowing about this, and so we should work on maybe improving our knowledge base. summarize some past literature in inflammatory bowel diseases, what people use, does it work, and then examine some of the work I've done under Dr. Saha's direction and also examine some opportunities for the future. So we'll start with inflammatory bowel disease. As we all know, lifelong diagnosis consists of ulcerative colitis and Crohn's disease. Patients go through periods of active disease where they're more symptomatic. They then might have periods of remission. I'm not saying anything new here. They might also be going through one or multiple surgeries to go through surgical cure options, and then they might start medical lines of therapy after that. And those medical lines of therapy might be increased, decreased, changed, depending on their type of disease. Currently, it's estimated to be 3 million adults in the US. Unfortunately, that incidence and prevalence is increasing. And we've seen this with both ulcerative colitis and Crohn's disease as countries continue to become industrialized and adopt maybe more of a Western type of lifestyle. And so, historically speaking, it's a relatively younger type of disease. Ulcerative colitis was first reported in the 1800s. And as countries have become more and more industrialized, there have been more and more cases. So that's worldwide, but in Olmsted County, where Mayo Rochester is located, they've been tracking these cases for the last 3 decades, and those continue to go up over time as well. So the incidence and prevalence are increasing, and then it's got quite a significant burden. So those burdens include hospitalizations, ED visits. They might include medication costs, the cost of delivering an IV therapy in the outpatient setting. They might include last-minute ambulatory visits with their IBD provider. We estimate maybe $10,000 per patient per year, times all of the patients that I outlined in my last slide, approximately $50 billion per year to the annual healthcare system cost. But this is just the direct costs. A lot of the studies are kind of unable to calculate these indirect costs, most notably IBD patients, when they're standardized against their peers, oftentimes have unrealized education potential. They might go through early retirement. They might have some form of absenteeism. And so this lost productivity, I would argue, maybe elevates this $50 billion to more than that. And so this is quite a significant burden currently and is expected to increase based on what we know. And even in the best of situations, if we do a really good job controlling their disease, their quality of life for these patients is still worse. And so this was a study that basically controlled for age and sex compared to their peers without ulcerative colitis or Crohn's disease. And so even in those best case scenarios where they have remission or controlled disease, these patients still have worse quality of life than their peers. So this presents an opportunity. It's highly prevalent, it's going up, high burden, and even if we're doing a good job, they have worse quality of life. And enter integrative health. What are we going to do for some of these patients that maybe we cannot always improve their symptoms, or we can't find maybe the more, measurable outcomes in order to kind of change their medications? We're kind of stuck. And so I'd like to take maybe the next 10 minutes or so to review what integrative health is, so we can kind of all be on the same framework in terms of knowledge and how to talk to patients about this. So early research, I think we can all debate how long some of these things I'll talk about today have been around. But when we put pen to paper or randomize patients to some of these trials, really a lot of the research started to kind of become into popularity in the 1980s to the 2010s. At the time, the term complementary and alternative medicine was very popular in these studies. And at the time, the WHO defined this as essentially healthcare practices that are not a part of the country's conventional medicine or not fully integrated into the dominant healthcare system. The NIH basically said the same thing, but they went a step further, define complementary as used together with conventional medicine and alternative as used in place of. There were also a lot of studies around this same period asking patients, okay, well, how exactly are you doing these things? Who are you seeing? And at the same time, those studies were showing that complementary and alternative medicine was actually used in conjunction with allopathic care on the whole, rather than in place of. And so you can see how this term complementary and alternative medicine became a little bit problematic because in fact, most patients are just doing the two things together, seeing the clinics that we all participate in every day, and then maybe doing some of these things on the side. And so integrative health really started to replace CAM as terminology in the mid 2000s. And these have become clinics that have incorporated conventional medicine with complementary and alternative medicine to really focus on delivering like holistic care to the patient and also focus on adding value to the patient's life through multimodal approaches. These providers are often family medicine trained MDs and DOs currently. However, fellowships in integrative health are available to all specialties, whether you're surgically trained, medicine trained, or family medicine trained. And so if you want experience like this, or if a young trainee wants to get more practice, it doesn't really matter what discipline they kind of grew up in terms of medical training. But before I move on from this slide, I think it's just important to lay this groundwork because you'll see on a lot of my slides the term CAM is listed. However, for the sake of today's conversation, IH will also be listed at times, and the two for today's talk is kind of interchangeable. So what does this look like? On the left-hand side, we might have some sort of orally ingested supplement or botanical drug, probiotic, prebiotic, food as medicine, or diet. In the middle, you might have more psychological practices like mindfulness or spiritual practices or psychotherapy. And then on the right, you might have more what we consider like physical practices, meditation, yoga, tai chi, or they might be saying an acupuncturist or massage therapist. And so when I like to talk to patients about these things, I like to just categorize it into three broad buckets so that I can kind of discuss in simplistic terms and be on the same page as a patient. It really consists of an alternative provider. I'm not saying everybody does these things, but on the whole, these are alternative providers. These might be homeopaths, spiritual healers, naturopathic doctors in some cases. Non-prescribed orals, so orally ingested supplements. These are the probiotics, the botanicals of the world, and then consisting of self-help practices, the yogas, the tai chis. And that is in addition to prescribed treatments that, again, are being delivered in the clinics that we're all participating in every day. And this encompasses basically an integrative health clinic. They're providers that have been trained in at least the evidence that we have so far and trained to deliver these things safely and talk to patients about these things. It turns out, though, when you ask patients what they're using, this was a 2012 NIH survey from 90,000 patients. It turns out when you ask patients what they're using, that those oral natural products are actually a disproportionately higher number of what people are doing in real practice. And so if I were to draw the buckets again, they would actually maybe look like this, is that the non-prescribed oral bucket is actually much bigger than the other two buckets. And so we probably need providers who understand this literature place and understand this marketplace in order to shepherd patients through something that might help them. And so we'll talk more about what might help and what not, but I think it might be interesting just to understand how we got here, because as I prepared for today's talk, there was some very interesting, history for how we ended up with the paint buckets maybe being a little bit disproportionate. So at the time, the then director of the HHS, Dr. Lewis Sullivan, said this: as consumers shop for healthier food, they encounter confusion and frustration. The grocery store has become a Tower of Babel, and consumers need to be linguists, scientists, and mind readers to understand the many labels that they see. So I would pose to the audience, does it sound like anything has changed in 35 years? No. So yeah, I mean, the children's report came out yesterday, right? And I think we could see themes in what they talked about from Dr. Lewis Sullivan's quote at that time too. And so there was a lot of momentum. I bring up his quote because there was a lot of momentum at the time. Congress at the time was really focusing on the FDA's role. Again, maybe not much has changed. And as a part of those role-focused meetings, a lot of legislation was introduced. Most notably, the 1990 Nutrition Labeling and Education Act was signed at the time. It's basically the nutrition facts that we all see on the back of our food products every day. but there were several other bills proposed at the time. And one of those bills was the Nutrition Advertising and Coordination Act of 1991, which was really aimed to tighten regulations on supplements. And we kind of know where this is going, right? The supplement industry got upset. They tried to kill the bill. And it culminated in this very dramatic commercial in 1993 with none other than Mel Gibson. It's basically 2 a.m. He's in his kitchen and he's taking some vitamin C, and these cops show up and arrest him. And he says, like, come on, guys, you know, like, it's vitamin C, like in oranges. And then the screen goes black and it says the federal government is considering classifying most vitamins and supplements as drugs. They've already conducted raids on doctors' offices and health food stores. Could raids on individuals be next? So very dramatic. You can look this up afterwards. It's like a 2.5-minute long commercial. I don't know, less money for commercials back then. But it worked. In 1994, President Clinton signed the Dietary Supplement Health and Education Act just 1 year later. And that did a couple important things. I'm only going to highlight one aspect of that bill today. It made supplements a category of food, and it shielded them from pre-market approval that drugs, biologics, and medical devices need. And so only post-market enforcement was possible at the time. Things have changed a little bit, but at the time, it was estimated that there were 4,000 of these products on the market. And so maybe it was like manageable for all of us to talk about and know about. Today, though, it is estimated to be an 80,000 plus product marketplace, representing a $60 billion industry domestically and a $200 billion international market. And so maybe what was once manageable has become a bit unmanageable. And so we probably need some sort of system to help patients through this process, at least understand what the literature is showing us so that we can talk to patients about it and maybe add something to their lives that could help them. And so with that knowledge in mind, I'd hope to convince you next that a lot of our patients are using these things and we're probably bad at knowing about it. So it's highly prevalent, high prevalence in the general population. And in 2012, the Council for Responsible Nutrition published a 4-year survey asking 2,000 patients on a yearly basis what they were taking. Basically, 70% say they were taking some sort of non-prescribed supplement. Turns out the Council for Responsible Nutrition is 100 supplement makers. So take this data with a grain of salt. However, these people are not supplement makers. The Memorial Sloan Kettering, Harvard School of Public Health, the Fred Hutch Cancer Center studied 40,000 patients over 13 years, and again, had similar results. Maybe half of them were taking non-prescribed oral supplements. And then they broke it down, interestingly, into age groups. And so those who are 65 plus were taking some of these things at a clip of maybe 70% or so. And even those 20 to 39 were maybe at a 45% prevalence rate for taking some of these non-prescribed supplements. So not only is it highly prevalent, in some cases, this looked a little bit different when I first put it on there. In some cases, patients aren't telling you about it. And so not only is it highly prevalent, in 2019, UT Southwestern surveyed a bunch of cancer patients and basically found a third of those cancer patients are again taking non-prescribed orals. But then within that group, a third, so maybe 300 to 400 patients, either omitted the information from their provider or didn't tell their provider about it. So not only is it prevalent, in some cases, patients aren't discussing it with us for whatever reason. And even if patients were discussing it with us, it turns out that most of us are actually just bad at talking about it and knowing about it. And so Rebecca Cohen, a geriatrician out of Boston, in 2002 published this nice survey interviewing a bunch of geriatricians in the Boston area. And basically, this is you being a great doctor and documenting 76 to 100% of what your patient is taking in terms of non-prescribed orals. And only 7% of you or your peers are doing those things. It turns out that the majority of providers are documenting 50% or less of what their patients are taking. But that was in 2002, you know, maybe the EHR has come a long way. Epic has really helped us. Unfortunately, updated data in 2018, this is a group out of Mayo Rochester again, asking cancer patients at their diagnosis and then again at 3 months. and comparing it to what their oncologist is documenting. And so even in 2018, most providers, about 48% of those polled, were still documenting either a minority or complete discordance, meaning like absolutely zero of what their patients were taking. And so even in a modern era, we're still not great at talking about this or knowing about it. And then on top of all that, I think some of the most interesting data I came across was, do patients even care about proof? And so these two studies were in inflammatory bowel disease patients. So this 700 patient survey asked, well, do you regard a scientific foundation as important for your use in this kind of category? 52% of respondents said they either didn't care or they were indifferent. And then this study went a step further and asked, even if a study produced negative results, would you continue to take what you're taking? And about a fourth of patients said, yes, I would continue to use complementary and alternative medicine regardless. And this has been replicated the same year in this case. 65% of 1,000 patient survey said, again, even in the face of a negative study, it wouldn't really make a difference to them. And so we all can probably think of cases that we've seen where this then has clinical consequences. This is the greater celandine plant. It's been touted to work on the intestines, improve sinusitis, may help fight cancer. Unfortunately, in 2012, 65 cases were caused acute hepatitis as of 2012. And so in some cases, these have important clinical consequences and lead to admissions that we all have to then go see and deal with. And so I bring this up as an illustration that this is what patients are doing. And so it leads to clinical consequences, or they don't want to talk about it. And so it's important to maybe start to address some of these things. And so again, as I alluded to in the beginning, though, some of these things have been around for thousands of years. And so I don't want to paint a completely dark, scary picture of these therapies. Many of them, to be clear, have existed for a long time and are completely safe to be utilized. And so it's really about adding synergy to our patients' lives, not just inflammatory bowel disease patients that I'm talking about today, but on the whole, we can probably work with our integrative health colleagues to really add a therapy that maybe our patients are missing for symptomatic control or quality of life, and add something that really helps their lives in the future. And so this is something that our oncology colleagues have known for a long time. So if you're an oncologist in the room, kudos to you. Or if you're listening on today's call, kudos to your society. The Society for Integrative Oncology was founded in 2003, and they've basically been studying these things since. And in 2018, they partnered with ASCO to endorse the SIO guidelines for during and after breast cancer treatment, including modalities ranging from acupuncture to oral supplements like ginger. And interestingly, in 2021, these integrative health clinics were available at 80% of NCI comprehensive cancer centers, including UW, which I'll get to. We are one of these centers that provides this care. But I also think, interestingly, 50% of community-based oncology practices offer some form of integrative health. And so this is potentially what gastroenterology with our IBD patients could strive to, because it's something that the oncology teams have been doing for a while. So we've kind of been through the background of IBD. We've talked a little bit about integrative health. I've convinced you a lot of patients are doing it. And so maybe let's summarize some past literature in IBD. So in general, why are patients using some of these things? I've looked at a lot of studies, and I feel like I don't need to tell you all of them, but basically broad strokes, it seems like when patients are asked why they're using some of these things within inflammatory bowel disease, it is a theme of, I want greater control over my life or my IBD. They feel like it places emphasis on the whole person. They want better control over their disease, or in some cases have had side effects from more conventional therapies. So the why is mostly, they want some sort of choice. Patients want to feel like they have a choice in their care. In addition to that, who is using these complementary and alternative medicines or integrative health within inflammatory bowel disease? On average, these patients tend to be younger. They tend to be obtaining more higher educational achievement, and they tend to be living in bigger cities on average, or they tend to have adverse events with conventional therapies, most notably steroids or antibiotics. And so, you know, the way I like to kind of interpret this is, you know, again, the demographics, but also maybe they just have more of a rough go with their disease, and so they want greater control or feel like they have a choice. So that is the who and the why. What about where? Turns out we don't know much other than, you know, about 700 Swedish patients almost a decade ago. And so this is really the only data I could find for where patients obtain their information when it comes to this stuff. And in 2016, a Swedish study basically just surveyed how are you obtaining your information when it comes to what you're taking. And most people at that time said like a friend, a next of kin or other. And I think most interestingly, you know, internet and media was less than 10% at the time. And so a lot has changed with social media, as we know. I think this would be a really interesting study to repeat and try to understand how patients are obtaining this data today with the TikToks and the Vines and the Instagram Reels. So yeah, so now let's maybe take a look at integrative health and inflammatory bowel disease therapies that have been put to the test. There's tons of them out there. I'm going to choose to only talk about two today, which is cannabis and turmeric, because those are often brought up in the IBD clinics. So cannabis for Crohn's disease, almost all of the information comes from a group led by Dr. Naftali, who for the last decade basically has randomized patients to some form of cannabis, whether it be cannabis cigarettes, cannabis oil, or a combination of like CBD and THC. And then they looked at primary outcomes known as the Crohn's Disease Activity Index, which is mostly a subjective symptomatic scoring system. And what they're trying to understand is, does their Crohn's Disease Activity Index burden decrease as they're randomized to these things? Most of the studies I'm going to reference also continued patients on their usual IBD care through their IBD provider. So for these studies, only 2 out of 4 of them had some sort of improvement in response or remission when it comes to the Crohn's Disease Activity Index scoring system. 3 out of 4 of them improved quality of life through the San Francisco 36 quality of life scoring system. And then unfortunately, when you start to measure more tangible things that are less subjective and symptomatic, no difference in measurable outcomes in the case of Crohn's disease was CRP and LFTs. And so cannabis for Crohn's disease might increase quality of life a little bit, might have more of a subjective symptomatic improvement, it seems like, but again, probably more studies are needed. How about for ulcerative colitis? Again, Naftali shows up twice, as well as a group out of the UK, Irvine. Again, kind of a combination of either THC extracts or cannabis cigarettes. In this case, they were looking at clinical remission or reduction in Mayo scores, which incorporates kind of like a gross endoscopic appearance to a patient's colonoscopy. And in this case, improved endoscopic appearance in 2 out of 3 studies, but again, kind of a subjective scoring system. Quality of life was either not reported or improved in 1 out of 3 studies. And unfortunately, when we start to measure more objectable outcomes, again, no difference in biomarkers, in this case, fecal calprotectin or CRP. So cannabis as a whole might help quality of life. You know, obviously you need to take that in context of the country you're practicing in and advise patients about how to do this safely. So that's cannabis. What about turmeric? I took this photo like 5 weeks ago. You could go buy all 4 of these tubs immediately after my talk if you wanted to. So it must be good in some way. Turmeric is the most used herb spice in the Indian subcontinent. It's often used as a part of Ayurveda, which is holistic medicine practice of the region. Its active ingredient is curcumin, which on paper makes a lot of sense. It's been shown to be hydrophobic and concentrate in the GI tract and inhibit mediators in inflammatory pathways. So on paper, makes a lot of sense. And its initial pilot study actually made a lot of sense too. So this is Dr. Holt out of Columbia University in New York. In 2005, they took 5 Crohn's disease patients and 5 ulcerative colitis patients, and basically gave them curcumin either twice a day for a month and then 3 times daily for a month. It reduced medication needs in all 5 ulcerative colitis patients, and again, reduced that Crohn's disease activity index score in 4 out of 5 Crohn's disease patients. It also, though, decreased ESR and CRP this time, and so that was very exciting, and it had no significant adverse effects on the liver or kidney. So that was, IBD as a whole kind of laid the groundwork for would this be possible. Unfortunately for Crohn's disease specifically, it's been a little bit harder to kind of continue this type of momentum. This is probably one of the more complete studies that I was able to find. This is a French group in 2020 their goal was to obtain surgical remission going into the randomization to curcumin plus an immunomodulator, in this case azathioprine. And so they resected these patients and then randomized them to these branches. And unfortunately, it seems like actually placebo was more effective for these perioperative patients, the placebo group having less endoscopic recurrence, actually. And so the data for Crohn's disease and turmeric has been a little bit more mixed. Ulcerative colitis, though, a Japanese group in 2006 randomized 90 patients with quiescent disease at the time to basically 6 months of twice daily turmeric. And at 6 months, they found that these ulcerative colitis patients have less relapses compared to those in the placebo group. And then they continued to follow them from 6 to 12 months, where they did not have to take this supplement. And unfortunately, that clinically significant outcome was lost. And so, maybe this suggests that these are temporal in nature. Patients need to continue some of these things when we do find something is efficacious. Again, in 2020, this group randomized patients with active UC this time to curcumin versus placebo in addition to their usual care. And in this case for UC, again, the dark bars are curcumin data, and these patients had clinical improvement or more clinical remission. And this study again demonstrated an improvement in both ESR and CRP, as well as an improvement in the IBD quality of life scoring systems. So it seems like curcumin and ulcerative colitis in particular might be a little bit more helpful when used in a conjunctive way with their usual IBD care. And so I could keep going on. I mean, I could give like a 3-hour grand rounds about all the various randomized control trials that have been done. There's a lot of literature out there, and as I've laid out with how popular this is, I think we need to enlist some of our integrative health colleagues in order to potentially add something that is helpful to our patients' lives in a safe and kind of predictable manner. And so in the herbs and supplements category, we could do this in a lot of different ways, but these are just some of the randomized control trials out there. The gut-brain axis has its own kind of bucket of randomized control trials, and then the ACG and the AGA do have some sort of guideline statements on diet and inflammatory bowel disease, but that constitutes its own bucket as well. So, I'm sure you've thought by now there's an elephant in the room, right? These studies are difficult, and it's difficult to interpret them. It's also difficult to conduct them. These patients are heterogeneous. They have different phenotypes within their UC and their Crohn's disease. They might be undergoing surgical interventions, and so how do you control for the need for that? In addition, their IBD provider might be changing medications on you, might be elevating their medication dosages. There's also confounding factors. These patients live in the real world, and so they might need antibiotics for a different disease process. They might be eating different things. It's also difficult to blind patients, particularly in things like cannabis or more physical practices like acupuncture or massage therapy. How are you going to blind a patient to that? Nearly impossible, I would say. And then, of course, integrative health takes time. Some of these interventions take time in order to work, and patients need to adjust to kind of the new life they're living with this chronic disease. And so with that in mind, I'd like to take the last couple minutes of the talk to understand some opportunities for the future, and maybe review some of definitely review some of the work I've done with Dr. Saha over the last couple years. And so as we think about this, we have an opportunity for intervention. And it turns out that there's a collaborative named the Osher Collaborative. And this is a group of institutions that is focused on providing integrative health to their patients and improving patients' quality of life and treating them in a holistic manner in order to kind of help with these difficult diagnoses. And it turns out UW is one of these places. And so we are an Osher Center for Integrative Health. We joined the Osher Collaborative in 2022, 2021. And we've had integrative health around, championed by Dr. Rakel at that time for basically the last 3 decades. It was started mostly in 2020 or 2002. So this is something UW has been doing for a while. Now we're a part of this fancy consortium. It consists of 11 institutions around the world in this case, mostly, tertiary academic centers in the US. Karolinska Institute in the top row there is in Sweden. But we have an opportunity here to collaborate with a lot of universities that are already doing this work. And so what we tried to do is take some old concepts, understand what our UW patients are doing, and kind of lay the groundwork for our own IBD clinics, and then also try to figure out if our patients are interested in being referred to our integrative health providers within the IBD sphere, and then track those patients over time. And so this started my intern year, and I won't belabor the point, but basically we made a survey and we presented it to all comers in our DHC IBD clinics from the summer of 22 to the summer of 23. What we ended up with was 181 patients approached, leading to 164 completed surveys. And it's in keeping with other past studies, we've found that 84% of our respondents are using some form of integrative health. And similar to other demographic data and other studies, our patients tend to be more highly educated. They tend to have a longer duration of disease, have used a biologic therapy, or have had previously related IBD surgery. So that is kind of the who within our UW clinics. What about what patients are using? Actually, a higher percentage than some of the past studies in our clinics report self-help practices. So 78% of our patients report using self-help practices, and then 54% report using non-prescribed oral agents. And then we went a step further and asked, okay, well, why are you using your non-prescribed oral supplement, whatever it is? Is it treating your IBD? Is it treating your general health? Or is it doing something else? And then we kind of grouped what patients were taking into various buckets. And it seems like if you take out vitamins and minerals, or make vitamins and minerals their own buckets, or make direct nutritional supplements their own buckets, that the rest patients perceive are treating their IBD. And so I think this is an interesting, data point, just because a lot of patients are perceiving that this is doing something for their disease, yet, as I laid out in the beginning, we're not discussing it with them. So there's a little bit of a contrast there. And speaking of not discussing it with them, patients are also reporting that they don't see anybody else for this, kind of keeping in line with prior studies. Most patients are saying that they're only seeing either their PCP or their gastroenterologist. And so again, I think demonstrating another opportunity where integrative health could help some of these patients address what they're taking and why, and maybe do it in a safe manner or add something valuable to their life. So with that in mind, we then started asking patients, well, are you interested in a referral to our Osher providers, our integrative health colleagues? About 2/3 of them said no, but 1/3 of them did say yes, that I would be interested in this. And within that group of 1/3, almost all of them were CAM users. And so is there some sort of way we can be asking patients when we room them, perhaps? Are you taking something? And then if you're interested in this, are you interested in going to our integrative health colleagues? That is something we're thinking about to create a referral process. But we have started to refer these patients, and our natural next step, well, if patients are interested, let's refer them. Simple enough concept. And so since 2022, what we've done is basically 103 patients have been referred from our IBD clinics to our integrative health providers. Of those 103, 62 went on to then have an integrative health visit. So conversion rate maybe 60% or so. And then of those 62 patients, they've constituted 115 total integrative health clinic visits over the last 3 years. And then we became very interested. So what is this doing for our patients? And so we actually have patients, this is a part of a natural process already existing as a part of the IBD clinics. Patients fill out a 19-question quality of life questionnaire corresponding to their IBD quality of life before they see an IBD provider. And so the idea became, let's have them fill that out as a natural part of the IBD clinic. Then if they get referred, let's track their referral. And then when they come back to IBD, let's compare their quality of life before and after. And so what we've done is really compare these two blue time points, which is before IBD provider, or sorry, before integrative health provider with their IBD provider, and then coming back to the IBD provider after seeing integrative health. We ended up with 97 patients who were referred to integrative health. 44, unfortunately, either for some reason never filled out the quality of life questionnaire or have not yet been seen by IBD after going to our integrative health colleagues. So we ended up with 37 patients with pre and post quality of life data. 16 were referred but never seen that we compared them to. And what we ended up with was about, average age of 40 years or so, predominantly females who ended up being seen by integrative health, keeping in line with Dane County demographics, more white patients on the whole, also more Crohn's disease patients, and then predominantly biologic therapy or previous IBD-related surgery. So in terms of the data, lower score equals better quality of life. And so these two bars are the same patients seen by integrative health once, before on the left, after on the right, and then these are referred but never seen, before and after. So as Haley mentioned a couple of weeks ago, a bit of a womp womp moment, if you will. Those who were referred but never seen did have a decrease in about 2 for their quality of life metrics compared to basically nothing for those seen by integrative health. But that got me wondering, is it actually the time scale that matters here? We've talked about how these things take time and realization of the benefits take time. And so it turns out that there's basically between these two bars for those referred but never seen, there's an extra 250 days or so where they're coming back to the IBD provider. So it begs the question, is there a gap here, and is it actually too soon to kind of understand a difference for what this has done after just one visit with integrative health and one visit returning to their IBD provider? And so then we took a look at, okay, there's actually 16 patients that were seen by integrative health multiple times, and of those, 7 have seen IBD and integrative health more than once. And so we have multiple follow-ups on these people. And a little bit less of a womp womp moment, these people do have, and they're achieving an absolute quality of life score that is better than the people who were never referred. And in addition to that, they're achieving this in maybe like 90 to 100 less days than their peers who were never referred. So I think, an optimistic finding overall is that those who are seeing integrative health have a better absolute value to their quality of life metrics and are realizing that potential at a shorter period of time. Certainly, we need to track these patients for longer. So some lessons, our patients are mostly seeing GI providers or their primary care providers. The majority of patients are utilizing some form of CAM, as we discussed. Those who are using CAM are interested in integrative health, and then it may positively impact quality of life, but likely takes multiple visits over time. So some next steps that we're planning on, we do plan to interview our IBD providers to understand their perceived benefit. We then also plan to go approach the patients, understand what value did this add to your life, and then also potentially a prospective study. And if I were to add a bullet point to this, I was actually just talking to somebody from the University of Utah yesterday who's a friend of mine from med school. Turns out, they are kind of collecting some of this data too, so we could potentially make some collaborations between institutions as well, if I were to add a bullet point about this. So, I've reviewed IBD. I've convinced you a lot of people are doing this. We've summarized some some past literature, and we've examined opportunities. I'd like to at least leave you with some resources. If you want to go to your clinic today and refer somebody to our OSHR colleagues, our integrative health colleagues, you can do that. You can directly refer to any of these subdisciplines within the OSHR Center, or you can send them to one of our MD or DO colleagues. We were able to put inflammatory bowel disease consult as a part of our research here, and so that is something that we're continuing to build as a part of this work. And so you can do this for patients within UW. It's usually covered by Courts insurance. Other insurance options, I'm not 100% sure. The American College of Lifestyle Medicine also has free seminars and training in some of this. And so if you want some more experience, the ACLM is a very good resource to do that. They also have conferences if you're interested in going to some of those. Finally, the National Center for Complementary and Integrative Health is run by the NIH and is a great resource. You can type in what you're interested in the top bar here. In this case, I typed in curcumin, and it spits out this nice kind of summary of background, how much do we know, and what have we learned so far. And so that can be a helpful resource to you. In addition to that, the NCI runs a section for health professionals, and actually similar to UpToDate, like a patient printout as well. And so if you go to the NCI's website, you can click on a patient PDF or a health professional PDF. And then similar to like the UpToDate patient printouts, you can have a conversation about what is on that website with your patient. The Natural Medicine Database is a subscription-based service. However, I believe the library, if you're a faculty member, the library incorporates this subscription for us, and so you can type in what you're interested in to that. And I think a nice thing about this is it gives you interaction checkers based on what we know, and then also gives you pregnancy data based on what is known so far, as well as an adverse section. And then finally, the Consumer Lab is a group that basically goes to Walgreens and CVS and other markets and buys some of this stuff and then reviews the literature and the ingredients within some of those things, and that's available online too. So those are some resources for you, and you definitely feel free to use any of them. With that, I'd like to say thank you to many people who have made my residency what it has become. I couldn't have done this work without Dr. Saha's direction, and then certainly within the GI department, Drs. Lucy, Grimes, Spiel, Lamelli, and Caldera have all donated their time to me to kind of shepherd me through this process. Nimrod and Trevor especially have been great mentors to me. Our family medicine collaborators, Dr. Hirakatar, Drs. Williams, and Kiefer, have been instrumental in kind of starting some of this collaboration. Our medical school contributors, including Jennifer and Dalton, they were hustling and filling out some of these forms with the patients for us, and so I couldn't have done this work without them. Finally, my co-chiefs, Geraldine, Haley, Mazen, you guys have made me a better leader, a better communicator, and have really challenged me to kind of think outside the box this year, and I'm gonna miss working with you guys every day. I didn't talk at all about this, but Dr. Zakowski mentioned it. The cooking class has been a passion project, and thank you to all the residents in the crowd who have either willingly or unwillingly participated in the cooking class. It's been really fun to be in the kitchen with you guys, and I hope you guys enjoyed doing that and enjoy it in the future as well. And then residency wouldn't be the same without Andy, Dr. Schnell, Dr. Holland, Dr. Zakowski, and our admin team, who I contact pretty much every single day. And then Sala, my fiance, and my parents. So don't forget to link the session, and then here are all my references. Should I leave this up longer? Sorry. If you want my references after this, they're afterwards. But yeah, I'm happy to take any questions.
Thank you so much for a wonderful presentation. I'm going to turn the microphone over to Dr. Schnapp, and then if there's any questions in the audience, I'll run up and bring the microphone.
Great talk, and you ended perfectly. So thank you. I have two questions. One, when you refer a patient to integrative health, did you record, was there a change in management or what the impact of that visit was? Did they change their probiotics, or make any recommendations that would make you think to look for changes in quality of life? And then the second question is, I know there's a lot of studies looking at the consistency of ingredients in many of these supplements or
Yeah.
natural products. How do you take that variability into account? Do you have recommendations for a particular manufacturer, et cetera, for many of these things?
Yeah, it's a great question, Dr. Schnapp. So in regards to changes within the visits, we have not yet looked at that, but I think we should and need to, of course, because as I laid out, lots of confounding variables in all of this data, particularly, what changes within the integrative health visit or what changes in the IBD clinic within, this time period for patients. So we are interested in looking at like what interventions these IBD patients go on to have. We only, in terms of like collecting data, it's difficult, but it really only made sense to obtain the MD provider visits at this time, or the MD or DO provider visits. But some of these patients are also being directly referred to acupuncture or massage therapy, and so it kind of, you can go down the line of like, okay, well, which data are we going to collect? And so for the sake of like simplicity and understanding just what we're doing on the ground right now, we kept it just, okay, how many people are going to the MDs or DOs within the Osher Center? And we have not yet looked at like the interventions within those clinics, but we definitely would like to. And then the second question regarding makeup of the manufacturer or like what is being used within the studies. Yeah, again, a huge issue. A lot of the studies publish how the supplement was made in terms of how is it extracted or what is like the chemical makeup in the methodology sections of the studies. And so I think I'd be interested to hear from our integrative health colleagues on the call how they counsel patients regarding one particular manufacturer, but some of the manufacturers then advertise like as compared with like this type of extract. And so I think when we look at supplements that are used, that's what we kind of have to go on, is that like which supplement maker most aligns with what has been published, which again is a very difficult kind of marketplace to keep up with. Yeah.
Congrats on a great talk. I'm going to follow up with what Dr. Schnapp just said too. I just think as Christy Bartles, rheumatology, as an autoimmune doctor, I would also just say that sometimes the purity of these things comes to question too, as to whether you're introducing neoantigens. Any concern about, or have there been any reports of flares of IBD on people on natural products? It would be maybe one question. My second question is just a practical question. Is there any opportunity to do e-consults for these things, recognizing that people for like courts and things like that,
Yeah.
these are capitated patients, so we maybe don't want to increase cost of care, but maybe we could get kind of like common denominators on these referrals. Like
Yeah.
this is the bundle that we usually recommend. Any opportunities there?
So regarding the first question, I think what I heard you ask at the end is like, is there any neoantigens being presented from these supplements within the IBD? Yeah. Oh, like adverse outcomes because of the supplements, you mean? Yeah, so some of the negative studies absolutely have led to actually like some more flares of IBD. I didn't kind of highlight those today, but again, I think kind of demonstrates the necessity for those patients who are interested in using these things, making sure that we do so in a way that harnesses the power of our integrative health colleagues to do this safely, especially in a Crohn's disease patient who might have like a particularly difficult phenotype of disease. And so before we tell them not to do it, maybe we should refer them and have those visits. And then regarding e-visits with our integrative health colleagues, it is something that is possible. And so Doctors William Kiefer, Hera Qatar, as well as the other providers, they have e-consults within the Department of Integrative Health. I don't know how to specify, like patient would prefer e-consult. I guess you could add that to the comment box. The wait times for, as with everything for integrative health right now, is rather long, but they do see e-consults over the course of Wisconsin, or over the geographic region of Wisconsin. Yeah, great question.
Thank you for a really great talk, Lucas. My question is regarding some of the data that you showed really early about patients continuing to use complementary and alternative medicines, even knowing that it may have negative side effects or, like was just talked about, IBD flares. And I was wondering if you have any advice or in talking and working with Integrative Health on how to help counsel patients to maybe avoid those or ways that we can work around trying to like get them to have supplements that either do no harm or may cause potential benefit.
Yeah, I think it's a multi-layered question, right? Because any individual patient in front of you might be safely using whatever they're using. It meaning like it hasn't negatively impacted their health. Does it negatively impact their finances because they're buying this stuff to any, to no benefit? Maybe. But I think it's, as we see individual patients, it's despite the fact that I, laid out adverse outcomes and patients still use this fact, important to remember that, it might not be making any difference and might not be adding any negative aspect to their life right now. And so almost part of it is like a psychological partnership with the patient. And so if the patient feels like they need to use this thing to give them greater control, and the literature tells me so far that there's no adverse outcomes, I kind of like, not to say shrug my shoulders, but it's almost like a tool, right? You can use that as a tool of trust with your patients. If the literature does, though, to your point out the fact that there's adverse outcomes here, you know, we can all use motivational interviewing, I guess, at times, and use those lessons. Maybe create some cognitive dissonance to understand, why they're doing that, and then come from a place of understanding on your side and say, here's what I know is that this thing you're taking actually causes flares, and would you be interested in maybe seeing one of our experts who really knows this literature really well, so that you can continue to have that conversation. So yeah, I don't have a great answer. It's a good question. I like to, I guess, just talk to my patients about why, and try to better understand. Yeah.
Here's a comment from Dr. Hirokatara. A few comments. First, regarding there are televisits that they have available.
Nice.
No e-consults yet, but working on starting that service. And third, as for supplements, their group uses consumer labs, which certify brands based on accuracy of ingredients and contamination, or recommend third-party certified products. So kind of looking at what's available in terms of making sure these products are safe. I think Dr. McCartney had a question.
Yeah, my mistake. Televisits rather than e-consults. Yeah. I forget because I'm a resident that e-consults aren't the same thing.
Great talk, enjoyable. From an ICU perspective, I felt like in the pandemic, things got more contentious with some supplements and people wanting to bring things in from the outside. So on the inpatient side, from an IBD perspective, what do you do when people are taking these supplements, they're getting admitted with a flare, they're sort of at their most crucial time? Do you allow it? Do you allow them to bring their own products? Do you work with pharmacy to try to mimic what they might be taking? And is there opportunities for those other complementary procedures, acupuncture or massage therapy on the inpatient side?
Yeah, good question. Yeah, I feel like on the inpatient side, it's like cold turkey. You're not taking any of this stuff. We'll do an endoscopy and probably treat you with steroids, right? So yeah, I'm not aware of any efforts. If there's any IBD providers on the call, I would love their feedback. But in my experience, yeah, no efforts have been made to kind of replicate the inpatient thing. And again, because there's really no studies to suggest like as you're having an active flare, this is going to benefit you. And in fact, any of the, a lot of the studies on inpatient medicine, impossible to control for some of those things. And then the second question was like acupuncture, massage, inpatient. I'm not sure. Dr. Schnapp, is that something we could get going? Yeah. Yeah, I don't know of any efforts to start that. It would be interesting, as you mentioned, like their most vulnerable moment. Could that improve their quality of life? Maybe make them feel better about some of the care that we're delivering within the hospital? A great question. Yeah.
I don't think that person is like currently volunteering. That was the only inpatient acupuncture I was
Oh, nice. Thanks, Devin. Did not know that. Hmm. Okay. Nice. Yeah, so we're all learning from each other here. That's great. I didn't know that. That's super cool.
It was a great talk. There was a slide that you showed where only 30% of the patients took you up on the offer for the consult. Did the other 2/3 give an indication why they didn't want? Because a lot of them are using complementary medicines, but apparently don't want guidance. Did you capture anything there?
Yeah, great question. We did not ask like, reasons for those people's response. I think after conducting many of the surveys myself, I think a lot of patients were just kind of like, yeah, I'm good. Like especially if their disease was already being well controlled, I think that they had a propensity to say, I don't need another person in this pot. I'm already doing just fine. Worse versus more those 1/3 that did say they want to see these providers were oftentimes some of our more difficult symptomatic patients who are endoscopically doing just fine. So that's maybe my inference, but no data to support that. Good question.
Well, we are out of time. Such great questions, such a great presentation. Thank you, Dr. Fass, for sharing with us all your knowledge.
All right. Thank you.